The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. Good day to you. Welcome to the next episode of TMD Demystified. I am Tony Urbanic. Today, we're going to talk about actually a very unusual topic. It'll need a little explanation. I hope you find it interesting. I certainly have. I had my eyes opened about this several years ago, and I'm finally getting around to trying to get the information to you meaning those doctors, dentists out there who are interested in treating TMD. The topic today is entitled TMD and Tardive Dyskinesia. Now, apologize to give you a word that you don't understand. I would bet that not 1 in 500, maybe one in 1,000 dentists go blank when I say tardive dyskinesia. So I will carry on and talk about this. But the issue that I want to discuss today, and that is tardive dyskinesia, which I will define in a moment, can create TMD. Now, as I've discussed many times, there are three primary causes of inflammation within the temporomandibular joint, which is chronic bruxism, punching and grinding, trauma, especially whiplash, but trauma of different varieties to the mandible and the face and the jaws, damaging the joint, creating chronic inflammation, and then functional malocclusion, which creates chronic inflammation within the temporomandibular joint. And tardive dyskinesia actually is a variant of bruxism, a variant of bruxism. So what is tardive dyskinesia? I'm going to apologize, and I'm going to read several paragraphs throughout this presentation to make it concise and meaningful. You can always play it back rather than me stumbling around. But I write a blog once a week also for patients, and I try to write the blog and the episodes of TMD Demystified on similar topics, if not the same topic, to place them side by side, one for doctors, this episode, and one for patients. Both doctors and patients need to know about all aspects of TMD, and this is just one of them. Not well known or well known at all regarding the effect of tardive dyskinesia on TMJ. So what is tardive dyskinesia? Tardive dyskinesia, TD, is a movement disorder that causes involuntary, repetitive body movements and is commonly seen in patients who are on long and short-term treatment with neuroleptic drugs. A neuroleptic drug is any drug that tends to reduce nervous tension by depressing nerve functions. This includes all types of psychiatric drugs and categories. According to a December 16, 2016 article in Scientific American, 17% of Americans fill prescriptions for psychiatric drugs each year. 17% of Americans use psychiatric drugs as of 2016, and this percentage continues to increase each year. It has been estimated that 20 to 50% of patients taking psychiatric drugs develop tardive dyskinesia. The most common repetitive motions associated with tardive dyskinesia include facial grimacing, sticking out the tongue, smacking the lips, and jerky to and fro motions of the jaw. Now, I am going to talk about this from a scientific point of view. I'm also going to use an article from the Oceaner Journal, pages 162 to 174 out of 2017. Again, I'm going to take this episode in segments, but the first segment is first to define what tardive dyskinesia is. So again, to demonstrate, and you will see this as a dentist, you will see these patients. You may not know what to call it. You may not even recognize it, but it can be any of these symptoms. You can also have, other body parts which are involved with rapid jerky motions, but the most common actually are muscles and motion associated with the cranial nerves, which creates smacking. You'll see people do that and lick their lips or stick out their tongue. It looks like this. And then the jaw movements, which are just involuntary. They cannot stop moving their lower jaw. And grimacing, facial grimaces of kinds, all associated with cranial nerves, and the most common emotions associated with tardive dyskinesia, which is created iatrogenically by psychiatric drugs. Now, as a dentist, obviously, you will not prescribe these drugs, but you need to deal with the side effects, the effects of these drugs. And tardive dyskinesia is seen in a large population, 17% of Americans are on psychiatric drugs of one kind or another. And roughly 20 to 50% of patients taking psychiatric drugs will develop rapid motions associated with tardive dyskinesia. So that is the definition that we're dealing with, and it actually can create temporomandibular joint disorder. Why? Because just like bruxism, which is forceful clenching or grinding, any continuous rapid motion, constantly, and we're talking 24/7, except when the patient is sleeping and the motion is overridden. But while awake, these patients have no control of this, and eventually a certain percentage of them will damage the internal structures within the temporomandibular joint, creating chronic inflammation, which creates the usual symptoms of TMD: headache, earache, jaw pain, neck pain, tinnitus, subjective hearing loss, vertigo, upper back and shoulder pain, arm, hand, finger tingling and numbness, and locking. And later on in this presentation, I will be discussing two separate patients that I have in my practice, recent patients. I've seen this for many years, but I selected this topic because just within the past month, I had two patients of mine who developed TMD symptoms secondary to their tardive dyskinesia. And it is quite striking and saddening, actually, to deal with these patients. All of them are aware of their problem. Some of them are even aware of where it comes from. Some are not. And then it's, in one case, and I'll discuss it in a minute, up to me to sit down with the patient and tell them why they have TMD symptoms, which are related to their continuous, rapid, jerky jaw motions. So that is the definition and description of tardive dyskinesia. The incidence is literally 2 to 5% of the population. 2 to 5% of the United States population develop one level or another of tardive dyskinesia, because 17% of the population is on psychiatric drugs, and 15 to 30% of the patients who are on psychiatric drugs develop tardive dyskinesia. So it's a rather common problem if you know what you're looking for. All right, so you need to know, for your general knowledge, what types of drugs, and there's various types of drugs, and I won't get into the details, the pharmacology, which I can, but I won't. I will just again quote this study, which is nothing more than a review of contemporary updates from, again, the Oceaner Journal, 2017, pages 162 to 174, which talks about medication-induced tardive dyskinesia, a review and update. So first of all, the etiology of tardive dyskinesia. The occurrence of tardive dyskinesia is, again, as I stated, estimated to be 2 to 5% of the population annually, and the condition occurs in 15 to 30% of those who receive long-term treatment of antipsychotic drugs. Predilection is fairly well known. Risk factors for developing tardive dyskinesia are the use of both typical and atypical antipsychiatric drugs, older age, females, previous brain injury, dementia, and the African and African American race. So it's more often seen in the blacks. The drugs that are associated, the categories of drugs, I'm not going to mention trade names, but the categories obviously are antipsychiatric drugs, anticholinergic agents, antidepressants, antiemetics, anticonvulsants, antihistamines, decongestants, antimalarials, antiparkinsonian agents, anxiolytics, which would include your SSRIs, and mood stabilizers, stimulants, which would include your ADHD drugs, which is a rather long litany of the categories of drugs that, if used too long and too much, will create rapid and continuous involuntary motion of the lower jaw, the tongue, and the facial muscles, which can eventually lead to chronic damage and chronic inflammation within the temporomandibular joint, which can lead to TMD symptoms. That is a lot of different medications that can actually create tardive dyskinesia. So, again, this came to my attention and desire to tell my dental colleagues about this who are interested, and I assume anyone who is watching this has some level of interest in treating TMD patients. Now, if you're going to treat the TMD patient, you have to know all the parameters and all the different circumstances of which you're going to see. And the fact that I'm, in my career, have treated thousands and thousands of patients, both surgically and non-surgically, surgically only for the past 12 to 14 years, 36 years of treating TMD problems surgically, and then stopping that and determining a much better course of action treating it non-surgically using a device that unloads the temporomandibular joint, which I've discussed so many times on these episodes. Won't go into that. But two recent patients actually tripped my desire to talk to you, my colleagues, about this. The first patient was about a month ago, and she actually had been under treatment since July of 2023. And she's an 80-year-old woman. Remember, this is seen, the incidence increases with age. So it doesn't surprise me and shouldn't surprise you now that this particular patient is elderly, 80-year-old female who had absolutely egregious facial grimacing, smacking, and motion to the point where it interfered with her speech. I had to really pay attention and focus on listening to her as she tried to talk, because you can imagine placing your tongue and the tongue itself, because of the motion of the tongue while you are trying to speak, getting her through the protocol using the Urbanic device, which was started on her like any other patient, 24/7 for 2 months, and then nighttime only indefinitely. So we started her treatment back in July of 23, delivered on July 31st, 2023. I'm looking at my notes here. And then to follow up to the point where she developed 80% of her TMD symptoms were gone. Now, this particular patient, her primary symptoms were chief complaint, ear pain, jaw pain, and jaw locking. She also had earaches, reported earaches. Those were her primary symptoms. And her workup included the usual, getting their list of symptoms and pushing on the joints to see if they were painful, therefore hot, therefore inflamed. That was certainly positive. And did this all through her continuous jaw motion and difficulty in communicating with me because of her long-term use of psychiatric drugs. Very nice woman, by the way, very pleasant woman. In discussing it with her, don't be afraid to discuss these issues with patients. I mean, 17% of the population is using psychiatric drugs. You are a doctor. You need to be able to confront this fact, whether you like it or not, or agree with it or disagree with it or not, and to be able to talk with your patient on the level that is one way or another helpful, and explain the best way you can as to what you're observing, what your diagnosis is, why your diagnosis is what it is, and then your recommended treatment and why that would be the appropriate treatment for the purpose that the patient came in for. So this patient, 80-year-old female, very nice, presented to me not with trying to correct her tardive dyskinesia, which when I walked in the room, I immediately thought, oh my God, does she expect me to fix this? Well, no, she had typical TMD symptoms of jaw pain, ear pain, and jaw locking. So she came back in January of 2024 and stated that 80% of her TMD symptoms had now diminished or gone. Excuse me. And this was ideal and not unexpected. I fully expected, using the device correctly. She had been in nighttime for some time, sleep time only or nighttime only. She did do the 24/7 for 2 months. And I made a special note that in her case, besides the fact that her temporomandibular joint symptoms had significantly decreased, she said that it feels more comfortable with the device in her mouth secondary to her tardive dyskinesia. It did not stop her tardive dyskinesia. What she said, though, was with the device in her mouth, the tardive dyskinesia was much easier for her to deal with, is basically what she told me. That doesn't mean, I am not trying to say we need to try to treat tardive dyskinesia with one of these devices. That this is an anecdotal comment from one patient, okay? And I admit that. I don't want to take it any further than that. But on the other hand, if I get 2 or 3 or 4 more patients come in and say, wow, I can deal with my tardive dyskinesia better when I have this thing in my mouth, well, then I will maybe make some different judgments or do some other investigations. But for the time being, just leave it as an anecdotal statement from one patient that stated with the device in her mouth, not only were 80% of her symptoms diminished, decreased, or gone, but she was able to deal with her tardive dyskinesia. It felt more comfortable, she said, in her mouth. And I found that interesting, and I knew right then that I was going to need to create an episode on TMD Demystified about tardive dyskinesia. The second patient is a 53-year-old female who had presented for the following symptoms. Her chief complaint was ear pain and fullness in the ear, like you've been swimming and can't clear your ear. She also reported frequent headaches, recurring earaches, ringing in her ear, fullness in her ear, shoulder and arm pain, arm, hand, finger tingling, and numbness. And she was placed on a device using the usual protocol, starting out 24/7 for 2 months, and took her through the protocol. And we finished her up, and she stated 95% of her symptoms were diminished or decreased, and wrote a success story. But in the process, I noted that she had obvious tardive dyskinesia. It wasn't extensive like the prior patient I described to you, but it was, I wouldn't call it minimal, but it was kind of one of these things every 10 or 15 seconds, every 5 seconds, you know. That's not normal. That's tardive dyskinesia. Or it could be a little of this, stuff like that. That's a grimace, that's a tongue thrust, that's, you know. Yeah. And I asked this patient, she did not bring out the fact that she had tardive dyskinesia. The prior patient actually knew the proper name for it. She says, I have tardive dyskinesia, the 80-year-old woman, and was able to discuss it with her openly, and I felt very comfortable. This particular 53-year-old female, I didn't think she actually knew that she had tardive dyskinesia. I recognized it. But to investigate it during her process, during the treatment episodes that I had with her in the office, I asked her if she was on any psychiatric drugs. And she said, oh, yeah. She says, I am. I said, well, what drug is it? And she said, citalopram. Uh, Yes, citalopram. Actually, the trade names would be the most common trade name is Celexa, but there are many others. And it is an SSRI. And she had been on this drug for 30 years. And so I was not surprised. So when she told me she was on an SSRI for 30 years, I literally sat down on my little stool and decided I was going to need to tell her why she had TMD, because in her case, let me look at my notes here. She did have mandibular tori, but the constant motion of the jaw certainly contributes to bruxism and will integrate with the problem, creating chronic inflammation and therefore symptoms. So I sat down with her and we talked about the problem and the iatrogenic cause of her temporomandibular joint problem using psychiatric drugs and creating tardive dyskinesia. And she took it very well. I mean, she was interested. When I say took it very well, she was very interested in what I had to say because I knew and could describe tardive dyskinesia. I knew what the symptoms were. She knew she had some symptoms, and she said, "Well, this makes sense to me now." She says, "I much more understand my problem," which is the only point that I wanted to make. And the point is that, as I said, she ended up with 90 at point in time, 95%, her statement, 95% of her symptoms, which I previously stated were diminished or decreased. She wrote a nice success story. And now she knows that what her tardive dyskinesia contributing factor is. And she also, as I definitely recall, she said, I've really wanted to get off this stuff a long time. And I said, I think that would be a good idea. She says, I know that it's very difficult. And I said, yes, it is. But you need to talk to your physician. Now, myself as a physician, even as a physician, I would not take it upon myself to try to monitor or to wean or to take a patient off any kind of drug that I did not put the patient or have the patient on. That is not my place. My place right now, and you know, after stopping, discontinuing doing any kind of oral or maxillofacial surgery, my only place in life, medically, dentally, is to now treat patients non-surgically with TMD and develop our network of providers throughout the United States who also use the Urbanic device and protocol to treat TMD. That is my only place. It is not to counsel. It is not to treat. It's certainly not to help people overcome the symptoms of tardive dyskinesia. It is a fact, though, that I did not bring out that in almost all cases, once the damage is done neurologically with these neuroleptic drugs, the symptoms do not diminish in almost all cases. So once you see the problem, it's pretty permanent and increases with time. And the 53-year-old female that I saw, she thanked me for bringing it to her attention and said she will work on this with her physician to try to discontinue these drugs. But 30 years of SSRIs definitely can cause tardive dyskinesia. So I hope I've enlightened you a little today about this. It's not one of my favorite topics to talk about because I know it can create conflicts of various kinds between doctors and patients pharmaceutical companies and doctors and pharmaceutical companies who do not tell patients, the doctors who prescribe these drugs and the pharmaceuticals who create these drugs, they know what the side effects are. It is well documented in multiple studies. Again, I refer you back to the study that I quoted. It has a litany of, I think, 130 some other articles. Let's see here. Yeah, 125 articles that are noted as references to this review article on tardive dyskinesia. All kind of things are known about it. And now those who are interested enough to watch TMD Demystified know enough to recognize patients with tardive dyskinesia. If you feel comfortable, and I encourage you to feel comfortable, be able to discuss this with patients, be open with patients, whether you feel really comfortable about it. Your job is to enlighten patients as best you know how, with reason and with comfort. With that being said, I invite you to become interested in becoming a network provider for the Urbanic device and protocol. We have a in-person seminar coming very soon on April the 19th in Franklin, Tennessee. That's April 19th, 2024, where I will, and my staff will teach everything known that we can tell you about TMD and how to treat TMD and become a provider, which includes 6 CME credits. If you would like to learn more without a seminar or without taking our online course, which also leads to your ability to use the device, you can go to our website, www.urbanictmj.com, where you can sign up to take the online course to use the device and protocol. If you'd like to discuss any part of this with me personally, I can be reached at tony@tmjservices.net. Our Director of Marketing Education and also our COO, Dr. Naomi Williams, can be reached at naomi@tmjservices.net. So that'll be it for today. I look forward to speaking with you on the next episode. And I think that you will hopefully be as interested in the next episode as you were interested in this episode. So for today, I am Tony Urbanic, and this is TMD Demystified.